So I will be presenting a case of double transcatheter valve-in-valve implantation in the tricuspid and pulmonic position for carcinoid heart disease. I also, unfortunately, have no disclosures. So our case begins with a 61-year-old female with a 6-month history of episodic diarrhea and flushing who presented for evaluation of progressive edema, exertional dyspnea, and palpitations for 3 months. Her initial echocardiogram showed normal LV systolic function, but was notable for severe tricuspid regurgitation with a severely dilated right atrium and right ventricle. Specifically, the tricuspid annulus was dilated with incomplete coaptation, and as you can see, markedly restricted leaflet mobility. The pulmonic valve was actually also affected, although not well visualized on TTE. On transesophageal echocardiogram, moderate pulmonic regurgitation can be better appreciated. I should also note that there is no evidence of a PFO or any left-sided valvular abnormalities on either TTE or TEE. Further investigation revealed markedly elevated urinary 5-HIAA concentrations, which is the metabolite of serotonin, multiple hepatic and pulmonary lesions on CT with biopsies that confirmed metastatic carcinoid syndrome. The patient was started on somatostatin analog therapy for systemic carcinoid and underwent surgical bioprosthetic valve replacement of both valves. The tricuspid valve was replaced with a 31 millimeter Magna Ease mitral valve and the pulmonic with a 23 millimeter Magna Ease aortic valve. The surgery was successful and the patient had clinical relief of symptoms. And she actually continued to do well until about a year later when she presented again in recurrent heart failure with NYHA class 3 symptoms prompting further evaluation. Unfortunately, she was found to have recurrent severe TR of the bioprosthetic valve with associated RV dilation and dysfunction. She also had mild tricuspid stenosis with a gradient of 6. On TEE in the lower images, you can further appreciate the thickened leaflets with evidence of malcoaptation, giving rise to a severe central TR jet. There was no obvious evidence of a thrombus or a pannus at that time. Evaluation of the pulmonic valve showed moderate pulmonic prosthetic stenosis, and in combination with the tricuspid findings, these were concerning for early prosthetic valve degeneration from a recurrent carcinoid process within a year. At this point, redo cardiac surgery with mechanical prosthesis was considered. However, this was deferred, particularly in light of pending surgeries for liver and small bowel resection for further management of her systemic carcinoid. Therefore, the decision was made to proceed with percutaneous valve replacement. The patient underwent successful dual transcatheter valve-in-valve with a 23 millimeter Sapien 3 valve in the pulmonic position and a 29 millimeter Sapien 3 in the tricuspid position via bilateral femoral vein access. Postoperatively, there was no evidence of a paravalvular leak, and the gradient across the pulmonic valve was significantly reduced from 39 to 8. Here you can visualize the final positioning of the dual valve-in-valves. The patient was discharged a few days later after an uncomplicated hospital course. This is her repeat echocardiogram on 6 months follow-up. There is no evidence of any residual tricuspid regurgitation. She does have some mild pulmonic stenosis with a mean gradient of 20. So to conclude this case, just 1 month after her valves were replaced, the patient was able to safely undergo partial hepatectomy and resection of her small bowel mets. At 10 months follow-up, she continues to do well at functional class 1. Lastly, I just wanted to go over a few important review points. So carcinoid heart disease is the leading cause of morbidity and mortality in patients with carcinoid syndrome. And medical therapy, unfortunately, is only palliative, and valve replacement is really the only effective treatment available out there. Bioprosthetic valves have become increasingly favored over mechanical valves due to reduced risk of thrombosis and lack of need for systemic anticoagulation in a population with underlying coagulopathy from liver dysfunction. And despite what I just presented, early bioprosthetic valve dysfunction is relatively rare in this population. And when it does occur later, it's usually due to thrombosis and not recurrent carcinoid. transcatheter valve-in-valve therapies are emerging as a feasible, minimally invasive alternative approach to reoperation in cases of bioprosthetic valve dysfunction, especially in high-risk patients such as this patient. And non-aortic transcatheter valve-in-valve implantation is relatively uncommon, but the data available that's available now suggests that it can be safely performed with a relatively high success rate. Thank you.
Well, as a second-year resident,
Third year. Applying for fellowship.
You definitely have a future.
Thank you.
So congratulations, and I hope it's an intervention too.
Yes.
Don't get crazy ideas about EP and whatever. I don't know. Fantastic case.
Thank you.
Yeah, no, I think it's really good. You talked about, I think, some of the things that were immediate. You know, as we hear the case, some ideas come through my mind, and I write notes, and then I look at your next slides, and then I cross off the things that I want to ask notes about. So it's good. But the biggest thing that is there is what's the cause of this early degeneration? And I think there's two things. One was the thrombosis part. So my first part is, did you guys try a Coumadin trial, or was the patient already on Coumadin, or where was that aspect of it? The second thing is, if you don't think thrombosis was the part of it, do you think that they just waited too long to do the resection of all this other stuff, and that's why this happened? And are the surgeons at some point, when the patient then fails these valves, going to go back in and then do a full re-replacement of these valves and put in mechanical ones or something like that?
Great. So for the first part of your question, because there was no evidence of thrombus on her echo or a PANIS, we actually did not try a trial of anticoagulation, although that has been studied, and with bioprosthetic valve dysfunction from thrombus, that's certainly reasonable. And then sorry, can you repeat your second question?
The second one was, why do you, if you don't think thrombus was a part of it, do you think that the carcinoid just affected these other valves, or? Yeah,
so in this case, even though it is rare, recurrent carcinoid process leading to plaque deposition has been reported, and unfortunately in our patient that was what was believed to be the cause of it. And if she has recurrent carcinoid process affecting her valves again, then possibly, I mean, it's really hard to say that you can do another valve-in-valve on top of a valve-in-valve, so I think at that point she would have no option to undergo redo cardiac surgery, but because she was able to get her partial hepatectomy and small bowel resection, I think the chances of that is really low, and the reason why it was put off for a little bit was because she had undergone a lot of other treatment modalities for it. She had done the somatostatin analog therapies that's recommended. She had undergone hepatic dearterization and was being tried dearterialization, and she was being tried on PRRT and everolimus. So I think I don't know if it was actually the patient's choice, but those alternative modalities were being pursued.
I just had Wakas Qureshi, North Carolina. Just had a question from one of your slides. Can you go back where the pulmonic valve is being inflated? So it's more of a technical question. I've never inflated once.
Yeah,
but,
it's loading. Sorry.
Does it need to be coaxial? I mean, there needs to be parallax removed when it's getting inflated. I saw it was inflated and not in. I mean, is it like TAVR? Like,
was this under TE?
Does it need to be?
Did they do TE at this time? Okay.
Yeah, I think this is the one. I guess.
Yeah, it's pretty much like TAVR. You have find the base of the annulus and you put the marker on it and I agree. It's a little off here in the alignment, but you know what? The most important thing is you have the bottom of the skirt below the old valve in all views, and if you know that, then you're going to be okay. But you're right. If it were more coaxial, you could have more confidence that your skirt was inferior enough.
My gut tells me they weren't able to get the C-arm angle, and they used TE. That's probably what it looks like. They got very close and said, "This is the most we can do." Yeah.
So what was the plan for her perioperative anticoagulation? She went for a major liver surgery.
Right.
small bowel, resection. So
Right.
was discussion of
And that, right, so that was like mainly the reason why she was recommended not to undergo mechanical valve prosthesis. For this patient in particular, she was discharged on dual antiplatelet therapy with aspirin and Plavix, and in carcinoid heart disease that's metastatic, and you have liver dysfunction and underlying liver coagulopathy. Anticoagulation becomes a question of risks and benefit. So she was not getting any.
For the current question, was there any time limit? You say no interruption in that for 3 months, for example. Would you say push for surgery for 3 months after?
The question is how long could they have waited? They already waited and burned through one set of valves. Yeah, they just have to probably just keep going and just get this done. So.
My only other comment is if you look at this deployment, a lot of movement during the tricuspid deployment.
She's displayed at 3 by.
Oh, sorry. Yeah, that second one was.
Well, either way, let's pretend there's a lot of movement. And so what I have done is I have put an active fixation lead in the LV and paced at 180. Yeah, and so I have done that before. Not a balloon tip, but an actual screw-in. The LV myocardium easily can accommodate it. Yeah, so.
Or if you're not as facile at doing active fixation as Paul is, you can just put probably a confida wire and just paste through that.
Yeah.
It's a little cheaper too.
Well, thank you. So Samir and I are going to tally up our numbers real quick, and then we'll announce a winner. Give us two seconds. Okay, in all honesty, we have this is an extremely narrow margin. We did on a 10-point scale, and the winner got 9, and the other person, the second and third place, I got 8s. So, Dr. Nguyen, congratulations.